know, Lorez is the leader on this issue in Colorado, so it's really great she's here to talk about it, and you should definitely utilize her when you ask questions. But some of you saw in that Kaiser video this creation of these exchanges. Each state has to create an exchange under the federal law. If a state doesn't create an exchange by 2014, the federal government will create this exchange for the state. So, as Lorez will talk about, there's some deadlines for the state to get moving on the exchange. But these exchanges are basically create a regulated marketplace of where individuals who don't have access to health insurance through their employer, or if they don't qualify for Medicaid or some other program, they can go into this exchange, and the exchange will offer insurance products that meet certain requirements that are in the bill. So as you can see, each state will have this new marketplace, and there'll be 3 different levels that you can purchase if you want to pay more to have more than what is going to be called the Essential Benefits Package. That's what the federal government is going to require insurance to cover. So it'll cover, we're not sure what it's going to have yet. The federal government's still defining that, but it might, hopefully it'll be robust and cover most things that we encounter, like diabetes, cancer, all these different things. But the basic plan, bronze, will have to cover those essential benefits. Silver and gold, you can purchase something more if you want in the exchange, if you have the money. The individuals that go into the exchange, a lot of them are the people that need the subsidies, that group that doesn't qualify for Medicaid, between that 134% of poverty up to the 400% of poverty. It's that group that they can only use or get that subsidy if they go into the exchange and purchase their insurance there. So a lot of people that don't have access because they don't qualify for a public program and their employers don't offer it, they can go to the exchange and purchase something they can afford. As you can see, the exchanges will have navigators to help people figure out if they should be going to the exchange, or maybe they'll qualify for Medicaid and they'll help them get over to that program. But there'll be navigators that don't have a bias of working for insurance companies, and will help consumers navigate the exchanges. And the exchanges have to include a nonprofit insurer. In Colorado, we have several. We have Rocky Mountain Health Plans, and hopefully, I would think that they would be part of the exchange. But they have to have a nonprofit insurance within the exchange. And then another thing that some of you probably heard about in the discussions by members of Congress during this whole health care reform issue is that Congress members will get their health insurance within the exchange also, instead of where they get it now through the federal benefits plan. So Congress members will go in there if they want to have health insurance that we pay for. They'll have to go into there and pick from plans and pay more if they want silver or gold.
Do we clap about that one? Congress has to pay what we pay?
Well, no, I guess it's more like it's part of their benefit of being an employee, so.
But the exchange is a state-based system, so.
The exchanges are the state-based system, so.
So their exchange might be different from our exchange?
I'm not sure, do they purchase within their own state?
Yeah, they would purchase in their own state. So our congressional representatives and senators would actually be purchasing in the Colorado exchange, or if we defer not to set up an exchange, then it would be, see, I'm short, so I gotta, or they would participate in a federal exchange that would be created in this state. Again, on our initial analysis, we thought about 300,000 people would be eligible for the subsidies. You need about 100,000 to really make this manageable. So we applied for a planning grant, almost $1 million, $999,987, because we're nothing if not exact in state government, to start really figuring out, doing some of the modeling to say, can we sustain an exchange? Likely we'll run some legislation this year. We're really working on bipartisan support, because we want to pull some of these exchanges and some of these issues out of the partisan fighting at a national level, and some of the constitutional fighting that's going on as well. And we're finding we're doing that with some potentially good success that would really start to set up a board and a quasi-governmental entity to run this exchange that would be accountable to the legislature, accountable to the public, but really be deciding how we create this marketplace in the state. And so there are federal funds for us to build this out. And there are some decisions we need to make right now, but there's still decisions we need to find out federal government. So what this essential benefit package is, we know that it is preventative services, we know it's mental health, we know it's substance abuse, we know it's rehab, rehabilitative, but how much of any of that, we don't know. And if the state goes beyond some of the federal minimum standards, we as a state have to pay for it. So understanding what they're going to require us to offer and what's still left over, we have to look at that. Understanding if we create 2 markets, the federal law requires 1 for small businesses and 1 for individuals. We convened 10 community meetings throughout the state, 6 in the Denver metro area, 1 in Alamosa, Grand Junction, Colorado Springs, and Greeley, and had over 1,200 people attend and heard some basic core concepts. 1, there should be a state exchange. We shouldn't necessarily leave this to the federal government because we got some great models in Rocky Mountain Health Plan and Grand Junction and Kaiser and Denver Health. How do we utilize what we have and build a really good, robust exchange? That even if we have 2 exchanges or we combine them into 1, we have 1 administrative structure so that we make this as sustainable as possible because the federal government will fund it through 2014, but then we as a state need to figure out how we're going to fund it, whether we add something to the premium, and so if you make it too big, too administratively large, we defeat the whole purpose of creating an exchange. And so we have some core values that will help us move forward as we build our state exchange. And we plan to have another 6 community forums this year and keep on going back for input until these are up and running in 2014.
And one other thing, Lorenz was mentioning there might be 2 exchanges, or small employers can also purchase within these exchanges. And so in creating the model, there's a discussion about whether we should have 2 different exchanges, 1 for small business and 1 for individuals. And as you can see from the slide, employers have to continue to provide health insurance or face penalties if they're a certain size. Small businesses under 50 employees, though, don't have a penalty for not offering health insurance. Instead, there's tax credits to actually help them pay for the insurance that they want to offer their employees, hopefully getting more small businesses to offer that to their employees. And I'll let Rez talk about this.
It's my favorite topic, cost containment. So again, I talked about this is really what got people to the table. I mean, as much as we want to say coverage is important, we know it is, and we know it contributes to cost when somebody's uninsured because they do show up in the emergency room. They do tend to not be able to pay the full cost of care. And most hospitals don't just lose money, they pass it on to folks that pay premiums. So it's been estimated that we pay some significant amount of our premium that covers the uninsured. And so expanding coverage is an important piece. We know how to do it, we've done it before, but if we don't do anything to bend that cost curve, we're just going to be spending more money. So a lot of the Congressional Budget Office estimates about the money we save really talks about how do we do care differently. So fundamentally, the way we pay for care, it's called fee-for-service, which means every time somebody does something, they get paid for it. There's no value about whether, well, was that good? Was that bad? Did it add to the health of the person or not? It doesn't pay providers to keep you healthy. It doesn't help them to keep you well. Their incentive is to do more. And so we need to fundamentally shift the way we pay providers to provide our care, to look at how do we incent the right kind of care? How do we incent wellness? How do we make sure that we take advantage of programs that work? So the challenge is also, we don't know exactly what works to bend the cost curve. We've done different models. We've tried different pilots. We've done things called medical home, where it's really care coordination. We've done it for kids, but we've never done it for adults. So what does that mean? We've done transitions of care. It's a model that was developed at the University of Colorado. It took seniors that were being discharged from the hospital. They did a 1 in-home visit and 2 follow-up phone calls and reduced readmissions by 50%. It's significant. I mean, 1, it's significant for people because most people I know don't want to be in the hospital. I don't think any of you do. So not spending more time there, being exposed to things you'd rather not be exposed to, means better health outcomes for the patient. It's less expensive, and people generally are healthier and happier. But what we don't know is how does that work for Medicaid? So for low-income populations, how does that work for privately insured? Can we do that same kind of model? There are things around looking at regions and how they're utilizing care, and can we do things different? When we started looking at the data as a state, we realized that the C-section rate in eastern Colorado is 7 times higher than the rest of the state. Now, I could say that's partly because it's rural, might not have access to docs, might be a personal preference for some consumers, but really that's also not the best outcomes. How do we figure out what investments we can make to drive better outcomes? And so what healthcare reform does, it gives us money to pilot all of these programs for bigger populations, to figure out what does this mean as we expand into other populations, to say, how do we get better value? How do we pay for the right things so that we get better outcomes? Because that's the way we get better health and save costs within the system. So that's a lot of what cost containment is about. And it's going to be challenging because I think it is easy to pilot. But if we don't actually then turn those pilots into policies, we're not going to be successful. And if we don't contain costs in healthcare, we're not going to be successful in healthcare. So this is where we're going to really need help from both individuals as we're paying for healthcare, businesses as we're paying for healthcare, states as we're paying for healthcare, to really push payers to say, how do we do this better? Next is Lee.
So as we mentioned earlier, I work on a grant for CCHI where we recruit baby boomers. There's actually a new nonprofit called Boomers Leading Change in Health, and we partner with them. And they're recruiting boomers, mostly in the Denver metro area, but to get involved in healthcare. And that's where, the interest has shown in Colorado that baby boomers, when they want to spend time doing extra things, especially as they retire, it's in healthcare. So it's also a group that is challenged with finding access to healthcare if they lose it. So as you can see from the slide, boomers have high uninsured rates because of what Lorez talked about earlier, the high costs for employers, and also because they may have pre-existing conditions, so when they go try to purchase private health insurance, they get denied, or because of rescissions or recession, and because of the recession, people have lost their jobs and they've lost access to the health care that they've had. So one way that the federal law attempted to deal with this between 2010 and 2014, when the whole law is implemented and we have exchanges, are these high-risk pools that we talked about, and that the slide, or that the movie showed too. The high-risk pools are Cover Colorado and Getting Us Covered in Colorado. And those two risk pools, basically if you get denied for a pre-existing condition, you can purchase insurance from those two risk pools. But there are costs to that. So after 2014, insurance companies won't be able to deny people for pre-existing conditions, and so they'll be able to purchase within the exchanges if they don't have access. Or if they're under that 134% of federal poverty, they will then qualify for Medicaid, which a lot of those individuals right now don't qualify for Medicaid. As Lorez was talking about, Medicaid's mostly children, pregnant women, the disabled. It doesn't cover all adults until 2014. And in the law, there's also prohibitions on discriminations based on gender, and there's also limits on what they can charge premiums based on your age. Insurance companies can charge a slightly different charge based on age, but they set caps on that within the law. One of the big issues that you probably hear a lot about through this whole discussion and debate on the healthcare bill is the issue of what it does with Medicare and what it does to Medicare. And actually, there are many ways that it improves Medicare. First, it provides one annual visit to every individual who has Medicare, and that's helpful because without a copay. And that's helpful because a lot of seniors don't have the resources and they may not go to that annual visit and discover that health condition because of that copay. So it eliminates that copay, and it also eliminates the copays for preventive services, so that certain services are covered under Medicare that seniors had to pay copays for before. And we haven't talked too much about this, but there are some limits on what insurance and companies, including Medicare Advantage insurance companies, can provide, or it's called a medical loss ratio. And it's basically what insurance companies can pay out for medical benefits versus what they use for administrative costs and profits. And earlier, Cy was talking about that in the United States is way higher. It's around 20%. The law actually requires health insurers to spend 80% on medical services, and it requires Medicare Advantage plans to spend 85 cents on medical services. Right now, Medicare Advantage plans don't spend that much on the medical services, and they bring in more money for administrative costs and profits. So it'll require them to actually use the money for services. It also deals with the Medicare Part D donut hole. I don't know if some of you have heard about that issue, but Medicare pays for prescription drugs under Part D up to a certain amount. And after that, I think that's $1,500. And after that amount, there's a hole where individuals don't have any assistance from Medicare. They have to pay for their drugs on their own until a certain level again, at about $2,700, where they get help again from Medicare to pay for the drugs. And this was a cost savings in it being able to offer the prescription drug plan to seniors, but it also has, it affects some of the seniors with chronic conditions the most. And so the goal of the law is, first they had a rebate to try and help seniors deal with that hole, and then between now and 2020, they're going to close that donut hole so that these seniors with chronic health issues no longer have that donut hole and have to pay for the drugs on their own. And then also it creates a program under Medicare Part D that gets cost savings for providing those prescription drugs. Right now, the federal government pretty much pays full price for our prescription drugs for Medicare individuals. Before that, a lot of seniors had access to reduced cost drugs. They had a lot of savings. And so this allows us to, again, go back to negotiating with drug companies for what we pay for drugs for individuals in Medicare. And that these two, the Medicare Advantage issue and also the Medicare Part D savings is what helps to pay for some of these healthcare reform ideas. So I feel like we're being repetitive since you heard some of this in the movie. But as you can see, and we'll just remind you again, the costs of healthcare reform of the bill are about $980 billion over 10 years, which it's estimated that. But over 20 years, it is supposed to reduce the federal budget by $1.2 trillion. And as you've probably heard recently with discussions of repeal, actually repealing the bill would cost $230 billion, and that estimate was done by the Congressional Budget Office, which the movie mentioned is a neutral office that evaluates the cost of different healthcare or different proposals by the Congress. And I talked a little bit about this in the Medicare slide, but these are the different ways that they are going to pay for some of the healthcare reform bill costs. And as we talked about, that Medicare Advantage, requiring them to pay the actual price for medical benefits, saves $150 billion that can be put towards the healthcare reform. There's an increased premium for those on Medicare who have high incomes, and those are individuals with pretty high incomes. There's savings in the Medicaid and Medicare prescription drug programs, like I talked about. And then there's also hospital payment reforms. Some hospitals make a lot of money. I don't know if you've read some of the news, and it's not necessarily transparent what they provide in charity care, and they get a status of being, they get tax breaks from the government. So basically this requires hospitals to be more transparent in what they are doing in charity care and actually providing charity care, instead of, saying it's charity care, but also trying to go after the person and their credit. And then there are fees, like the movie talked about. An interesting one is tanning salons, but there are other fees on certain device manufacturers and insurers to help pay. And then reducing waste and fraud and abuse in public programs. There are different pilot programs to try and reduce fraud and waste. And then, as Rose talked about earlier, just improving our health information technology in healthcare can save us a lot of money. If not everything is done by paper, but instead we utilize computers and networks and get providers to use similar systems, we can save a lot of money in that piece as well.
So, sorry, this is where I get my exercise, running back and forth too, so that it's also about wellness. There are investments in wellness, and I should say this because this is a question that comes up a lot as well, that we need to really look at what are some of our long-term costs and how we are as a society and how do we prevent obesity and move into some of those public health realms so that we're looking for our future. But this is more the physical representation of what I was talking about, that through healthcare reform, we'll cover 500,000 people that don't currently have coverage. 300,000 of those are through the exchanges, so this private coverage. About 200,000 through the public market expansion. So again, it is significant. Again, we still need to maintain our safety net because there's still going to be people without coverage. The Kaiser slide said just undocumented, but I want to be clear, it's not just going to be undocumented because there is an opt-out for the individual mandate. If the premium is more than 8% of your total income, you're exempt from the individual mandate. There is a recognition of you can't just tell people to buy it if we don't make it more affordable. So this sort of 250,000, 300,000 that are left will be comprised of undocumented, it'll be comprised of people who can't afford it, as well as people who choose not to get it, who would rather forego and go after the penalty instead. So what it means for Colorado, on the next slide, is a lot of different things. We know that more people will have coverage. We think there are about 90,000 small businesses, nonprofits that might be eligible for tax credits. We'll know a little bit better after the tax year who actually applied for that. We have over 40 entities, unions, counties that have applied for early retiree help so that they can better hold on to that early retiree insurance. We have community health centers that will benefit. 3 have already received some pretty significant contributions in the state. That is Salud, Clínica Tapiac, and Valleywide, as well as Metro Community Provider Network will be able to expand their capacity. And again, it's just important to remember that healthcare dollars are a good investment in our economy, and especially at a time when we're thinking about how do we create that economic growth. For every dollar we invest in healthcare, it generates $2.44 in economic output. University of Denver did the study with New America Foundation and saw that a lot of this investment is local. Now, not all of this investment is efficient, and that's partly what we're going to try to do is how do we make those $2.44 more efficient. And so we have a couple of steps to still move on, but what I am going to let you know is we're getting down to the last, we're going to move really quickly through the last slides. So this is your 2-minute warning that your turn is coming up next.
So what are the next steps for federal reform? And I know out there, there were some different handouts, and one of them includes an actual timeline of healthcare reform, and I urge you to take that and look at that so that you know some of the specifics on that. But as you know, as we've talked about, the law will be fully phased in over the next 4 years. And so right now the federal government is busy making different rules and regulations so that they can provide the states information on what's going to be required, like that essential benefits package that we talked about that will be required of insurers. What's a medical loss ratio I mentioned earlier, what counts as medical care for insurers. So there's all these different regulations that are being worked on at the federal level. And then I'll let Lorez talk about the state policymakers and what they're doing, since she's right in the middle of it.
So the Governor Ritter issued an executive order in April of last year, sort of saying, what do we need to do to move ahead? How do we implement this? Colorado is really seen as a national leader. Because of some of the things we've done over the past couple of years, we're better positioned than most states for healthcare reform. And so we have some real great opportunities as we move forward. But one of the things Governor Ritter knew is that he wasn't going to be governor when this started to be, for the majority of it, implemented. So it was really our responsibility. And I should say this is not unique. We have 29 new governors, more than any time in history. At the same time, federal healthcare reform is moving to the state level. That's a big thing to take on right as you're coming to the new state, as well as really tough budget issues. And so really it was our goal to create an implementation plan. And so it's available on our website. There are websites at the end of this. It really talks about what we've done since March 24th and what we need to do going forward. But really it's focused on what grants and opportunities do we have to move forward. How do we break down some of the silos that exist in state government? Now I know you've never experienced that. That state government wouldn't be talking to one side to the other, but sometimes that happens. So this is really an opportunity really to give us, to tell departments, to let them know that we need to do a better job. We need to be more efficient. We need to be more elegant, meaning consumers should feel better because of their interactions with state government than worse. And so we haven't done a great job of that, and this gives us the opportunity to do that. So again, just to wrap up, the very last slide is that we still have challenges moving forward. It's healthcare reform came with a lot of grant dollars, but not always with a lot of administrative dollars. And so how we move ahead is going to be really important. Understanding the changing relationships both within the state and among state and federal governments, as well as just understanding we need to be flexible, and it's going to be important that we just continue to move forward, have patience, and really work on cost containment. So we put a whole set of resources, we put our emails and phone numbers, so you can find us any way you need to. So